I suppose it is a very good academic feast we are going to experience today. We have stalwarts like Dr.PMC sir, Ramkutty sir, Padmanabhan, and seniors like Dr. Gopika, Dr. Arathi, Dr. Kamala. And today's presentation is from Anandaburi Hospitals, presented by Dr.Gauri and analyzed by Dr. Kavya. Before going to the session, I would like to request Dr. Srijit to talk a few words. Over to Dr. Srijit.
Okay, thank you, Dr.Anju. And I particularly very happy to conduct and continue with this journal club. And for that matter, that I will personally congratulate Dr. Anju, Kanmani, and Padmanabhan sir and Ramankutty sir for being the faculty and organizing this journal club. And also, fortunate thank the doctors from team from Anandaburi, Dr. Kamala, Dr. Arathi, and Dr. Gauri for presenting this journal club. And we are very fortunate to be the senior faculty Dr.PMC Nair sir here, and we are very eager to watch the academics and journal club. So waiting to the academics to happen. So all the best wishes to the program. Over to Anju.
Thank you, Dr. Srijit. Dr. Padmanabhan sir, any opening remarks, sir?
Nothing.
Dr. Padmanabhan sir, any opening remarks? Okay,
No,
okay.
no.
So now I think we will go to the team to present the journal club. I would like to request Dr. PMC sir, senior and my teacher, one of the first neonatologist of Kerala, who has been trained in Australia and has been teaching all of us for a very great time. And I am so fortunate that sir has agreed to take part in this program and to teach us a lot. Over to Dr. PMC Nair sir for his opening remarks, his introduction, and to lead us to the subject proper. Dr. PMC Nair sir.
Thank you, Anju. Thank you, Srijit. No, actually, I have a small presentation also. Is it visible? Is it visible, audible?
Oh, visible and audible.
Actually, because there will be some confusions, and because the journal club today being perinatology, neonatology, I think I'm right to give a small introduction, so that otherwise it was some confusion with the Doppler and this umbilical artery Doppler screening. We have seen that is predictive of perinatal compromise, reduced stillbirth, increased preterm delivery, significant improvement in antenatal detection of IUGR. Actually, there's a revolutionary thing in the perinatology field, and it happened in 1980s. I'm sure when Dr. Ramankutty, Padmanabhan are all there, the house surgeons and all, but we must have seen a lot of perinatal complications, perinatal deaths, high-risk cases. All this could be detected and treated, or early intervention was possible because of these Doppler studies. See this, this thing is coming there. SGA improves the outcome in high-risk pregnancy. This is Cochrane review that you can see nicely the systolic and the diastolic waveform. And this umbilical artery Doppler, the progression from normal end diastolic flow velocity to decrease to absent to reverse end diastolic flow is what is very important, because it's got a positive predictive value in predicting antenatal asphyxia to the tune of 92%. And the wonderful thing is that it precedes fetal heart rate anomalies by 3 days. So that's a very great thing, isn't it? We can detect early and can step the steps and do something for the baby, and babies would come out well. So that is the basic thing about the Doppler. And this is the Doppler waveform. If you can see it nicely, there is a systolic and diastolic waveform in figure A. In picture B, the diastolic waveform is becoming reduced and it's totally absent. This is absent end diastolic flow. That is the term, absent end diastolic flow. And when you come to picture D, E, and F, what is happening? There is not only stopping a complete diastolic flow, there is a reversal of diastolic flow. There is a reverse end diastolic flow. So absent or reverse end diastolic flow velocity in the umbilical artery is suggestive of fetal compromise, and if you can act quickly, you can save the baby. So that is a major revolutionary thing that's happened. So the studies on Doppler study with absent or reverse end-diastolic flow. And this is the same thing showing, again, you can make out nicely the reverse end-diastolic flow velocity. Second thing I would like to say is about the nutrition. What is the regime in low birth weight babies? Cochrane and AAP has strongly recommended judicious parental nutrition. At the same time, start early aggressive enteral nutrition by within 24 hours of age, either with express breast milk or pasteurized donor human milk, and step up enteral nutrition and wean out animal nutrition. So that is the second point. And when you see early minimal enteral nutrition feeding, or what is known as MEN, it is we give around 10 ml per kg of breast milk per day, 2 hourly feeds. For a 1 kilo baby, it will hardly come to less than 1 ml. And this will stimulate the gut hormone release, greater GI motility, improve feeding tolerance, reduce cholestasis, better weight gain, etc. And the third point I would like to tell you is about the feed intolerance. So that is also a vague term, and different books give different connotations. Mainly is inability to achieve full feeds, vomiting, abdominal distension, abdominal girth more than 2 centimeters, increase, hemorrhagic gastric fluid, and Doppler metrics, which may show reduced intestinal peristalsis, gastric residuals more than 25%, and resistive index more than 0.785. This is from Frontiers of Pediatrics 2024, Ifran et al. And they have followed a similar feed intolerance regime also. And the NNF has clearly said that gastric residuals should not be routinely checked. In our times, every feed, before that you aspirate and see. But now it is said only if there is abdominal distension more than 2 centimeters, you do the aspiration. Vomiting, then complete absence of bowel sounds, blood-stained gastric residuals, these are important, and the vomiting bile is also significant. At the same time, green, yellow, or milky residuals, you don't have to stop the feeding. And also, the occult blood stools check is not at all to be done. Then another new thing they introduced in the study is the near infrared spectroscopy, or NIRS. This brain oxygenation, as well as planktonic oxygenation, can be detected by this, and in antenatal Doppler with absent or reduced end-diastolic flow, splenic oxygen imbalance will lead to feed intolerance, ischemia, and DC. So it's a big clinical dilemma. Delayed feeding, how long to delay? Because more you delay, more problems will be there. And throughout the world, till today, there is no current consensus on feed initiation timing in reversed end-diastolic flow velocity. So this is probably the first study I've come across and compared two groups with end-diastolic flow velocity absent or reverse, and studying about feed intolerance. When to start with one group will start at 6 hours, other group at 24 hours of age. We will come to the details. And NES is another area which is also mimic feed intolerance or sepsis. There will be abdominal distension, feeding intolerance, etc. This is the new modified Bell's classification. Stage 1 is removed. For the postgraduates, it may be useful. Stage 2 is pneumatosis. Stage 3 pneumatosis plus systemic illness. See, the first picture looks like just gaseous distension, a sepsis, or feeding some intolerance. Here, in the second picture, you can nicely make out the intestinal, the pneumatosis intestinalis, or intramural gas shadow in the ileal region. This is the Doppler study, and the surgery you can make out the ischemic cut, which have to be removed. So with this small introduction for 5 important points, I said, with this I'll stop here and invite Dr. Gauri to do the presentation. Thank you very much.
Thank you, sir, for that informative presentation. Or Dr.
Gauri. Dr. Gauri.
Good evening, all. Today is the journal club presentation on the topic initiation of enteral feeding as per current protocol versus as per clinical status from 6 hours onwards in neonates born with antenatal reversed systolic flow in the umbilical artery Doppler, a pilot randomized control trial. It was published in the Journal of Perinatology on 6th April 2025. The objectives of our study is to compare the effects of initiating feeds at 24 hours versus at 6 hours in neonates with reversed end diastolic flow and determine the incidence of feed intolerance and necrotizing enterocolitis. Design, it is a pilot randomized control trial. Methods, we've taken two groups of sample size 52, divided them equally into 6-hour group and 24-hour groups as how we started the feeding to assess feed intolerance, necrotizing enterocolitis, time to reach full feeds, sepsis, mortality, weight and gestation at discharge, and hospital stay. Results was that feed intolerance was observed in 14 neonates, that is 54% of our 6-hour group, and 17 neonates, that is 65% of our 24-hour group, with comparable NEC rates in both. Neonates in the 6-hour group achieved full feeds faster, that is 8 versus 11 days, and had shorter hospital stay, 17 versus 32 days. Death and sepsis rates were similar in both groups. Conclusion, feed initiation at 6 hours in reverse end diastolic flow neonates did not increase the risk of feed intolerance or necrotizing enterocolitis. We'll start with a small introduction. What is the importance of nutrition in very low birth weight neonates? Optimal growth of very low birth weight neonates depends on adequate nourishment. Total parenteral nutrition is initially necessary in small or sick neonates. Enteral nutrition is our cornerstone for long-term support. Early enteral feeding reduces catheter-related complications, risk of sepsis. Doppler abnormalities and risks. Aberrant umbilical artery Doppler, example reversed end diastolic flow, increases the risk of feed intolerance, necrotizing enterocolitis. Reversed end diastolic flow is often seen in severe intrauterine growth restriction. There's a study of near infrared spectroscopy findings, which shows that absent or reversed end diastolic flow neonates show splanchnic oxygen imbalance on antenatal Doppler. This increases their susceptibility to increase feed intolerance and necrotizing enterocolitis. As a result of this, postnatal gut conditions like they are prone to stasis, abnormal bacterial colonization, and invasion, increasing the risk of NEC. Risk rises with early introduction of enteral milk feeding and advancement of feeding. That's why we were scared to reduce the time in which we start the feeding. Systematic review by Darling et al. Has shown that NEC risk increases by 2.1 times with a 95% confidence interval in abnormal Doppler cases. The clinical dilemma here is the fear of NEC and feed intolerance, which lead to delayed and slow feed initiation till now, which in turn raises the risk of sepsis and TPN-related complications. As Sir said, there is currently no clear consensus on feed initiation timing in reversed end diastolic flow neonates. Role of minimal enteral nutrition. There is men benefits, that is systematic review of 8 RCTs, which showed that men reduced time to total enteral feeding can be reduced, hospital stay can be reduced, NEC risk ratio of 1.1 was obtained, that is with a 95% confidence interval. No RCTs included reversed end diastolic flow neonates. Currently, there are variable practices in starting feeding for reversed end diastolic flow neonates. It is ranging from 1 to 5 days currently. Jain et al. Had done a pilot study in which early feeds within 24 hours in absent end diastolic flow neonates were considered safe. Here, there was no increased risk of feed intolerance or NEC when we tried feeding them earlier. Aradhya et al. Had done a retrospective study where feed intolerance is common, but standardized feed advancement did not increase the risk of NEC. Rationale for our current study is that limited data on feeding practices in RED of neonates need to assess safe timing of feed initiation. This pilot trial compares feeding initiated at 24 hours, that is unit protocol that we follow, versus if it is initiated early, that is from 6 hours onwards, based on clinical status in neonates and if they have normal abdominal examination. Outcome measures that we've used. Primary outcome is the incidence of feed intolerance itself, that is until discharge or death. Secondary outcomes is the incidence of NEC, time to reach full feeds, duration of TPN use, days on intravenous fluids, probable and culture positive sepsis, in-hospital mortality, weight and gestation at discharge, and hospital stay duration. Materials and methods. Study setting is a regional neonatal unit in northern India. Time period spanned 15 months from March 2023 to May 2023. Study design is a randomized controlled trial. Registration and ethical approval was taken. Study population included eligible neonates were inborn neonates. Any gestation or birth weight were taken, diagnosed with a reversed end diastolic flow in antenatal umbilical artery Doppler. Enrollment was at 6 hours of life and after written informed consent from one parent. Excluded neonates were extensive resuscitation if it is required at 5 minutes with UPGAR score less than 7, shock requiring inotropes on day 1 itself, parental refusal of donor human milk if mother's own milk was unavailable, gastrointestinal or major congenital malformations, or any other contraindication to enteral feeding. Baseline measurements that we took were weight measurement using an electronic weighing scale, accuracy of 1 gram. Gestational age determination was using LMP and first trimester ultrasound, confirmed postnatally by New Ballard score. Randomization and masking was done at 6 hours of life. How it was done using computer generated random numbers in sealed, opaque, identical envelopes, allocation by independent observer. Groups A was 6 hours onwards early feeding initiation, and B was how we routinely start feeding, that is at 24 hours. Intervention, feeding protocol. Group A, enteral feeds was initiated at 6 hours of life. Group B, enteral feeds initiated at 24 hours of life. Eligibility for feeding is normal abdominal examination. Broadly, that was bowel sounds present, no distension, no gastric aspirates. Feed initiation volume below 1000 grams was 10 ml per kg per day. More than or equal to 1000 grams was 20 ml per kg per day. Feed was increased also by the same per day as tolerated. Feeding, if abdomen was not ready at 6 hours, reassessed every 6 hours until 24 hours. Mother's own milk was preferred. If not available, donor human milk was used with parental consent. Formula milk was not used in our study. Definition of feed intolerance that we used here is the presence of any two of the following. Gastric residuals, that is 33% of total feed volume on 2 consecutive occasions if our feed volume while we give was more than 8 ml. 50% on a single occasion if the feed volume was less than 8 ml. Abdominal distension was defined as girth increase more than 2 centimeters from baseline. Brown, bilious or bloodstained gastric aspirates. Vomiting requiring feeds to be withheld for more than or equal to 12 hours. Absent bowel sounds in 2 quadrants for 2 minutes, confirmed by a second observer. How did we manage the feed intolerance? Feeds were withheld for 6 hours and then reassessed. If improved, feeds resumed at 50% of our last tolerated volume and then increased as per the schedule mentioned before. Persistent intolerance, feeds withheld until full recovery. NEC, how do we define it here in the study, is as per Bell staging, Kliegman's modification from stage 2 onwards, we've taken as NEC. Full feeds was defined as 150 ml per kg per day. TPN was given via UVC or PIC based on clinical discretion, clinician's discretion, being when enteral feeds reached 120 ml per kg per day. Sepsis was defined in the study as definite sepsis was clinical signs of infection should be present, plus definite sepsis if it is positive blood or CSF culture. Probable sepsis is one or more of the following. Positive sepsis screen with CRP or procalcitonin, chest X-ray showing pneumonia, CSF analysis suggesting meningitis, or hemodynamically significant PDA, which was defined as diagnosed via echocardiography. Criteria was PDA size of more than 1.5 mm plus pulmonary overcirculation, that is left atrium to aortic ratio more than 1.4, isovolumetric relaxation time of less than 55 milliseconds, or systemic hypoperfusion, that is diastolic steal in descending aorta. Sample size, there was no prior trials specifically on reversed end diastolic flow outcomes, hence formal sample size collection was not feasible here. Targeted minimum of 25 neonates per group. Actual enrollments all REDF neonates born during study period were enrolled. NEC incidence comparison was done here with 4% versus 8% in both groups. To detect this difference at 95% confidence interval, we actually required a total sample size of 4,952. That is in group 1, when we divide, it should come up to 2,526, and in group 2, 2,426. For feed intolerance of 54% that we detected in our study, 14 people, and 65% with 17 in the other group. To detect the difference with 95% confidence interval, sample size of 2152 was required. That is 1,226 and 9,926. Statistical analysis was done using SPSS software version 29. It was done in an intention to treat approach. Categorical outcome variables were measured using chi-square test with continuity correction done, or Fisher's exact test if any of the expected cell size was less than 5. We got it in the exact state using Fisher's exact test. Numerical variables were tested for normality using the Kolmogorov-Smirnov test. Normally distributed variables were tested using unpaired t-test. Equality of variance was assessed by Levine's test. Skewed variables by Mann-Whitney U-test, and Kaplan-Meier analysis was used to represent the time to reach full fields. This is a brief explanation of the test that we used. Chi-square is an association between two categorical variables, significant or not. Mann-Whitney if it is skewed data. Fisher to get the exact probability in a 2x2 contingency test if it is less than 5 cells. Wilcoxon signed rank test for paired samples. If it is small size sample size, we normally use paired t-test, unpaired t-test, one-way ANOVA or two-way ANOVA. So now here, this is the flow chart. In neonates born with REDF, eligible neonates, we actually had a sample size of 68. Excluded neonates were 16 due to various reasons. That is 2 due to shock, 1 due to congenital malformation, 3 due to refusal for donor human milk, 4 due to they were referred to private hospital, and 2 due to abdomen being unfavorable till 24 hours, and 4 because at 5 minutes their Apgar was less than 7. So totally after exclusion, we got a 52 sample size, and they were allocated equally in the 6-hour and 24-hour group, 26 each, and analyzed. So baseline characteristics of our enrolled neonates was that there is only significance in 2 characteristics that we've checked in our enrolled units. That is, birth weight was more in 6-hour groups, that is 1.3 kg, or compared to the 24-hour group. This could be due to chance because we've randomly allocated it. Also in the gestational age, more gestational age was babies were found in 6-hour group compared to 24-hour group. Others, there is another significance that as we give more time, mother would have more secretion of milk. So we got first feed EBM for 24-hour group more babies than 6-hour group. Primary and secondary outcomes that we've analyzed here, feed intolerance that we noted as our primary outcome is lesser in 6-hour group, that is only 14 infants, and 24-hour group, 17 infants. Gestational age at discharge, in terms of weeks, we got it earlier. An earlier discharge was possible in our 6-hour group compared to 24-hour groups with a p-value of less than 0.05. And duration of hospital stay also was reduced in our 6-hour group, that is 17. Only 17 days were required in 6-hour group to be discharged compared to 32. These are the secondary outcomes that we've assessed with significant p-value. Survival function at survival function using Kaplan-Meier survival analysis test was done, and this is to assess our days to reach full feeds. And here we can clearly see that days to reach full feeds was earlier in 6-hour group compared to our other 24-hour group survival. So univariate analysis was done of assumed risk factors for feed intolerance, taking only feed intolerance as our variable. And in this, we could find that birth weight was increased in neonates without feed intolerance, and it is obviously lesser in neonates with feed intolerance. And gestational week, babies without feed intolerance went up to increased gestational weeks compared to babies with feed intolerance. The need for invasive ventilation is the most required here, and these are the factors with lesser significant p-value. Hence, invasive ventilation was required more in babies with feed intolerance compared to without. Discussion. Initiating feeds as early as 6 hours after birth with an advancement of 10 to 20 ml per kg per day resulted in no increase in feed intolerance or NEC compared to starting feeds at 24 hours in reversed end diastolic flow cases. Shorter hospital stay. Secondary outcomes were comparable between two groups. The feed intolerance overall incidence was 59%, consistent with previous studies that had already been done, comparable to the ADEPT trial with feed intolerance there being 51%, higher than Adel Mahmood et al. Trial that they had done where it was 37%, no increase in feed intolerance with 6-hour feeding versus 24-hour institution. Necrotizing enterocolitis, overall NEC incidence was 6%, notably lower than prior studies, ADEPT being 16%. Indian cohorts like Tewari, Bora, Jain, it was lesser than all of them. NEC rate in 6-hour group was nearly half of our 24-hour group, but not statistically significant. Sepsis and mortality, culture positive sepsis was lower in 6-hour group, 2 versus 5 cases. Mortality also lower, 3 versus 6 cases, though not statistically significant, linked to earlier weaning from TPN, shorter IV fluid use, early PIC removal, early discharge was possible. Shorter hospital stay and shorter duration of IV fluids in 6-hour groups, earlier gestational age at discharge, and higher discharge weights observed in 6-hour group. Strengths of our study is that it's the first RCT specifically evaluating 6-hour feed initiation RADF units. RCT design enhances the internal validity of the study. Inclusion of a wide gestational age range, including extreme preterm neonates. Use of BHM ensured timely feed initiation, reduction in hospital stay and IV fluid duration. Outcome alignment with meta-analysis by Ann RP et al. In our study reinforces the external validity. Limitations. Small sample size limits power to detect the statistical significance for rare outcomes like NEC or mortality. Low NEC event rate reduces the ability to draw definitive safety conclusions. Open label design with possible measurement bias. No gestational age stratification, which is critical in assessing NEC risk among extreme preterm neonates. Single center study may limit generalizability, especially where BHM is not readily available. Potential co-founders like SGA status, maternal factors, and antenatal steroids not fully explored. Conclusion. The study demonstrated that enteral feeds can be initiated as early as 6 hours in case of REDF if the abdominal examination is normal. All outcomes were similar, regardless of whether feeds were initiated at 6 or 24 hours, and birth weight was an independent risk factor of FI. I'll be handing over to Dr. Gauri.
Thank you, Dr. Gauri, for that excellent interpretation of the article. Or to Dr. Gauri, Dr. Kavi.
Good evening. I will be doing the analysis part. Randomized control trial. A randomized control trial is one of the most powerful and reliable tool in clinical research. These are prospective studies used to measure the effectiveness of new intervention or treatment. The critical appraisal of a journal article. This is a systemic process used to identify the strength and weakness of a research article to assess the usefulness and validity of research finding. Consort were created to ensure high quality presentation of the conducted RCT. I'll be using the 30 checklist items according to the 2025 consort. First question, identification as a randomized control trial. Yes, it is clearly mentioned. The title clearly states a pilot randomized control trial. Structured summary of the trial design, method, results and conclusion is clearly mentioned in the study. Next is the trial registration. Name of the trial registry and date is clearly mentioned. Protocol and statistical analysis plan, where the trial protocol and statistical analysis can be assessed. It can be assessed through the author of the study. Data sharing, that is where and how the individual de-identified participant data statistical code and any other materials can be assessed. That also can be assessed from the author. Funding. funding, the source of funding and other support, and role of funders in the design, conduct, and analysis and reporting of the trial is not clearly mentioned in the study. Financial and other conflict of interest of the manuscript authors. The authors declare no competing interest. Next is introduction, scientific background and the rationale of the study. It is clearly mentioned. The introduction discusses the optimal development of low birth weight neonates and the risk associated with reverse then diastolic flow, the current lack of consensus on feeding initiation in these cases, and the benefits of minimal enteral nutrition. Due to highly limited data on feeding in REDF cases, they plan this pilot trial to compare the outcome of initiating feeds at 24 hours as per the current unit protocol versus early initiation from 6 hours onwards based on the clinical status in neonates with REDF and a normal abdominal examination. This was the rationale of the study. Specific objectives related to benefits and harm is clearly mentioned. To compare, the objective was to compare the effect of initiating feed at 24 hours at 6 hours in neonates with reverse and diastolic flow and determine the incidence of feed intolerance and necrotizing enterocolitis. Patient and public involvement. The details of patient or public involvement in the design, conduct, and reporting of the trial is mentioned. The trial design, description of the trial design, including the type of trial, allocation ratio, and framework is mentioned. This is a pilot randomized trial with 2 groups with a parallel design and an allocation ratio of 1:1, that is 26 sample size in each group. This can be considered as a non-inferiority trial that demonstrate the early feeding protocol is not significantly worse as compared to the standard protocol in terms of feed intolerance and necrotizing enterocolitis. Changes to the trial protocol. Important changes to the trial after it commenced, including any outcomes or analysis that were not pre-specified with reason. The changes after the trial protocol is not clearly mentioned in the study. Trial setting. The setting was clearly mentioned, that is in a regional neonatal unit in northern India. Eligibility criteria. It clearly states the eligibility criteria, that is all eligible inborn neonates irrespective of their birth weight and gestation diagnosed with REDF in umbilical artery Doppler were assessed at 6 hours after birth and enrolled after obtaining return informed consent. The neonates requiring extensive resuscitation in shock and parental refusal to donor human milk was excluded from the study, and those with gastrointestinal and congenital malformation was also excluded from the study. Intervention and comparator. Intervention and comparator with sufficient details to allow replication is clearly mentioned. The detailed description of the feeding initiation time, that is 6 hours versus 24 hours, initial feed volumes, advancement rates, and management of feed intolerance is clearly mentioned. That is, in less than 1 kg neonates, the feeds were started at 10 ml per kg, and those more than 1 kg, it was started at 20 ml per kg, and it was increased at 10 ml per kg per day and 20 ml per kg per day as tolerated. Next is the outcome. Pre-specified primary and secondary outcome, including the specific measurement variables were mentioned in the study. That is, the primary outcome of the study is the incidence of feed intolerance. Secondary outcome included neck time to reach full feeds, duration of TPN, days of intravenous fluids, probable and culture positive sepsis, in-house mortality, weight and gestation at discharge, and hospital stay, of which only the hospital stay and the gestation at discharge was found to be significant. How harms were defined and assessed. The harms were clearly defined. The risk factors like sepsis were, the definition of sepsis and NEC was clearly defined in the study. Sample size, how sample size was calculated, and explanation of an interim analysis was done. As no prior trials had exclusively studied the outcomes in REDF cases, a formal sample size calculation was not feasible. Therefore, a minimum of 25 neonates per group was initially targeted. However, to ensure comprehensive data collection, all neonates with REDF born during this period were enrolled. If we calculate sample size with the current data of incidence of 4% and 8% NEC rates to find out the difference with 95% confidence interval, a sample size of 4952 will be required. And in our study, we have used only 26 neonates. Similarly, for feed intolerance of 54% and 65% to detect the difference with 95% confidence interval, the sample size of 2152 will be required. Randomization. 17A, who generated the random allocation sequence and the method used. The method used to generate the random allocation sequence was using the computer generated numbers. It was assigned to two groups, that is group A and B, by an independent observer using a sealed opaque identical envelope. The method used this simple randomization. Allocation concealment is done, assigned to two groups by an independent observer using sealed opaque identical envelope, that is NOS. Implementation, whether the personnel who enrolled and those who assigned participants to the intervention had access to the random allocation sequence. No. Blinding, this was an open label trial, so blinding was not done. The statistical methods used were discussed in the previous slides. SPSS software with intention to treat approach, chi-square test with continuity correction, Fisher exact test for categorical variable, unpaired t-test or Mann-Whitney u-test for numerical variable, and Kaplan-Meier curve for time to reach fulfill was used. Definition of who was included in this in each analysis were clearly mentioned as explained by Gauri. 21C, how missing data were not analyzed. Additional analysis like univariate regression and multivariate regression was also used to compare to analyze the independent variables. In univariate analysis of risk factors, neonates developed feed intolerance had a significant lesser mean birth weight, lower mean gestational age, and a higher requirement for invasive ventilation. Other potential risk factors were similar in both groups. On multivariate regression analysis, birth weight emerged as an independent risk factor for feed intolerance. Participant flow diagram. For each group, the number of participants who were randomly assigned received intended intervention and were analyzed for the primary outcome. Yes, a console diagram depicting the patient flow from enrollment till outcome is mentioned in the study as shown in this diagram. Total 68 neonates were involved. Of this, 16 were excluded and 26 were allocated in the 6-hour group. The next 26 allocated in the 24-hour group, and it was analyzed. Recruitment dates defining the periods of recruitment and follow-up of outcome, benefits and harm was clearly mentioned. The study was conducted between March 2023 and May 2024. And the trial was not stopped. Intervention 24A, the intervention and comparator as they actually administered. as they were actually administered, and concomitant care received during the trial of each group, both are mentioned. It's comparing the time of intervention, the type of feeds, and their advancement protocol, which is similar in both groups. The baseline characteristic of the enrolled infant, as described in the below box, is also mentioned. Next is the number analyzed, outcomes and estimation for each primary and secondary outcome. The number of participants included in the study, that is 26 in each group. The number of participants that with available data at the outcome time point, result of each group, the binary outcomes, everything is mentioned. The primary and secondary outcomes as mentioned below, that is feed intolerance, which developed in 14 of the 26 in the 6-hour group and 17 of the 26 in 24-hour group. And the neck and the secondary outcomes of neck, TP and IV fluids, which were almost comparable in the both groups. Harms or unintended events in each group is mentioned. Mortality has been reported, and it was seen to be attributed to sepsis and shock, with one NEC stage B case death mentioned. Ancillary analysis, that is any other analysis performed, including subgroup and sensitivity analysis, distinguishing pre-specified from the post-hoc. The univariate and multivariate regression was done for the subgroups, that is in the feed, to analyze the risk factors of feed intolerance was done. The discussion interprets the finding in light of previous research, highlighting consistency and discrepancies, and in re-emphasizing the safety of early feeding. The limitation of the study is clearly mentioned, that is the small sample size, as it is a pilot randomized trial. It is not generalizable. It is an open label trial, no blinding was done, and other confounding factors like small gestational age and all was not studied well. Thank you.
Okay, thank you. Okay, thank you, Javier. And so, Dr. Ramankutty, are you taking it over, or can I say some points? Hello?
Yeah, you can give your comments.
One or two comments is a very well executed study from Postgraduate Institute of Chandigarh. Actually, one of the co-investigators was my registrar long time back. But they should appreciate the guts to do such a study, because reverse endosteric flow in the umbilical artery. Usually, people are scared to start feeds. Maybe we wait for 24 hours, maybe 48 hours, and then slowly start like that. Anyway, so those 2 points are good. But one point I want to say, extreme preterms are not included in the study, though they said they included. It's 32 weeks plus minus 2.3. That means up to 34 weeks and around 30 to 34 weeks are in the 6-hour group, whereas in the 24-hour groups are slightly younger, 31 weeks. Similarly, the weight of the babies also were slightly higher in the 6-hour group. So that means slightly milder cases that come in the 6-hour group. So some bias may happen there. Other thing is number of cases, as I said, it should make it in a multi-center study. Then only such difficult situation cases will be more. Different centers should have been included. That is another thing. Then the study, they have mentioned gestational age stratification was not done. I don't know why. Even retrospectively, they can do it. Like 26 weekers, 27 weekers, 28 weekers, 30 weekers, 32, like that. Or some sort of gestation age stratification would also added value to the study. So this is all that I had to say. Anyway, what do you say, Dr. Ramankutty, about statistical analysis?
Thank you, sir. Over to Dr. Ramankutty.
Okay, I hope I'm audible. First of all, I think it's a fairly straightforward paper, which is not difficult to understand what they have done, and I would like to congratulate the people who presented and the person who critiqued it. They did a good job, and usually that is the pattern in these meetings that I find. All the residents are very much up to date in their knowledge, and I was very much happy to hear Dr. Madhujendran Nair. He gave a presentation which many of the things I really didn't know. Of course, I am not very up to date in clinical matters nowadays, but still it was a good thing to refresh or renew my knowledge, at least for the knowledge sake. The only point, 2 or 3 points I want to say about this. One is, first point is I don't really know the answer to that, but the thing is, is there usually when you do a clinical trial, you say that you have to approach a point of or a question of clinical equipoise. That is only when there is a doubt. So, from the way I think Dr. Madhan Chandran said that they did a very bold thing. I really don't know if that is a question of clinical equipoise, because if it is well accepted that is one approach is superior, then probably you are not justified in doing a trial. But then the ethics committee has passed it, so I am not really in a position to criticize that. Ethics committee or ethics board in an institution like PGI has passed it, so that probably it is their job to look into that. So we will accept that as. So second point is about sample size, which of course it's very small, but then that is probably one of the reasons why they could not do very much stratification and all that, because only 25 in each arm. But then it's a pilot trial, so you don't have too many people. But maybe now they can plan an extended study. So before we kind of develop any recommendation based on this, maybe it is better to have a multi-centric trial also. Whenever you have a single institutional study like this or trial like this, this approach is very good, that like you put it out like a pilot study. So then this whole discussion on sample size will not happen, because I have found that in many studies, especially this is for residents and young people trying to start a study and all, the major stumbling block, first number one, is the sample size. We have our own limitations on sample size because of the particular situation in the hospital, but the research committee looks upon it purely from a technical point of view, which I don't agree with. So if I am in that committee, I will say that you do the study with whatever is possible. But I have found that many people find that this is one point on which they can criticize. They always criticize. So it is one way of overcoming that is to say that this is a pilot study. Then they won't be able to say much about it. That is one point I want to make. And the second point is that it is obvious that the two groups were not balanced, because you can see that in terms of the birth weight, right? Birth weight or gestational age, one of those things.
Both.
Yeah, so they were not really comparable in that sense. So that is one pointer, that even if you do randomization, you may not get a balanced group, especially when the sample size is small. That is one of the reasons why we insist on a bigger sample size, and that is one of the reasons why we need a larger study. Of course, even this is a pointer, but we can always go for a larger study. So when you have this imbalance, then you cannot just simple comparison is not enough. You should have a multivariate analysis, and I think there has been a multivariate analysis, right? That is what the person who did the critiquing did, but I don't remember that table at all where there is a multivariate analysis. You can show that once more, it will be good. But a multivariate analysis is very necessary when you really don't have a balanced group. So these are only one of the some of the few methodological points I want to raise. Otherwise, this is a fairly straightforward study, and I hope the message from this, I think, is that there is some indication of evidence, but we need to have a higher or larger multi-centric trial before we decide on any recommendation. So that's all I want to say.
Okay, very good. Thank you, Ramankutty.
Okay, sir, you were telling about some slide and all. If sir wants, the slide is there, we can read out. No, is it from the?
Who showed that slide? I don't. I mean,
Yeah.
maybe my mistake, but I think I have overlooked that slide. Is there a slide showing multivariate odds ratios?
Kavya?
Gauri, that feeds intolerance in the chart or table undallo.
Sir, അതിന്റെ യൂണിവേരിയേറ്റ് മാത്രമേ ഇവർ കാണിച്ചിട്ടുള്ളൂ, ബാക്കി മൾട്ടിവേരിയേറ്റ് എന്ന് പറഞ്ഞിട്ടേ ഉള്ളൂ. Table ഇല്ല sir.
Is there in the text, is it?
It is not there in the study. That table is not there. They have told.
But do they report it in the study in the results?
Yes, sir. They have quoted. They have done a multivariate regression, but that table is not there.
Yeah, but in the results, at least they mentioned what is the multivariate odds ratio. If that is not there, then it's a major fault.
Any supplementary materials or okay? Continue.
Maybe it is there in the supplementary material. I don't know.
I don't know whether it is there.
There
are supplementary materials.
Comment, so not that important.
It's only about a table on multivariate, sir. There's no this thing on analysis table on the multivariate analysis with the odds ratio.
Okay. Thank you, sir. I think can we go to the discussion, sir?
Yeah.
Ramankutty, sir. Anything else? Dr. Padmanabhan, sir. Anything to add, sir? Dr. Padmanabhan, sir.
It's not my cup of tea. Neonatology is not something which I practiced for so many years. But Dr. Madhavan explaining the end diastolic flow and all was very nice to me. That is, you can hear me?
Yeah.
Okay. Therefore, that was very clear, very nice beginning. But I thought that certain things like, whether the patients are giving antenatal steroids, cesarean section or not, should have been there in the analysis, is it not? Especially cesarean and all will affect your postnatal feeding, whether the patient was a normal delivery or a twin or antenatal steroids was given or not.
I think antenatal steroids is routine. Like preterms coming in labor.
Okay, and cesarean is not there.
Is there any information on that, Dr. Gauri? Then breakup, did they say anything about antenatal steroids?
No, sir, it's not there. It's not mentioned about antenatal steroids.
Well, Dr. Madhavan, I was just recollecting for my last sentence, I would say, till 2007, I was working in Oman District Hospital, and by 2002 or 3, we had 14 ventilators in our place. And the senior consultant was myself with no training of absolutely neonatology. We never did end diastolic flow to start feeding, even at that time. When you said by 1980 it has come up, you can understand how much practice lags behind technology, because there was nobody to do an ultrasound. I didn't know how to do it, and others also were not there. Therefore, when you told me that 1980 onwards this has come, it hit me like a rock, I don't know.
But it must have come like here and there only, not even in India, maybe, I'm not sure.
When you were in SQH at that time, it was done.
Yeah.
It was done.
It came. Actually, one Tradinger, he is supposed to be a very important person. And he was working in same Sultan Qaboos University.
Okay.
So that's
So
why
he
it's
did
around
it.
77. It started in 1980. They started working for the delivery antenatal ultrasound and all that.
No, I'm asking you, in 1990s, you were in SQH. Were they doing in the babies
Yeah,
before?
yeah.
They were
Because
doing.
especially that Radinger was the person mainly involved. He was doing it, but we didn't know much about it.
My question is, nowadays in our, say, Anandapuri
Yeah,
place, who is doing
definitely,
this? Is
definitely.
it done
Yeah.
by the neonatologist or is it done by the radiologist? Because I find that in emergency. Yeah, tell me.
Obstetrician, basically, with the help of the radiologist.
Okay. The obstetrician does it with the help of the radiologist. Yeah, okay.
In most of the hospitals, I think, major hospitals definitely all have Dopplers. Isn't it, Dr. Arati? Yes, worked in KIMS in Anandapuri also.
Yes,
What do
sir.
you say?
Yes, sir. Majority, like nowadays, even the obstetrician does the ultrasound, antenatal, Doppler ultrasounds and all. But always it is the primary person doing is a radiologist. But it's even the obstetrician do nowadays the ultrasound, Doppler ultrasounds as well. Because especially the preterms and all, when they come in labor, they do the last image, emergency scans and all. If they don't get a radiologist, obstetrician has the skills to do now.
Don't worry, now AI will do it in no time.
Yeah.
Soon. Okay.
Thank you, Padmanabhan sir. Thank you, Padmanabhan sir. Over to Dr. Arati, madam. Madam, kindly take part in the discussion and throw your comments, madam, because you are mentoring and.
Yes, sir. Actually, what we do, like what we practice, I will tell, like it's a preterm or a low birth weight baby who comes, we initially give a men feed, that is minimal enteral nutrition. It is not involved in their calories. So actually from day one, actually soon after birth, we advise on the breastfeeding, but it's very rare like mothers get the breast milk soon after birth. So usually now what we do is we wait for 24 hours and see if mother get EBM, because even 1 ml 2 ml is sufficient nowadays. We don't wait like for 6 hours or 24 hours, provided if it is an absent or reverse end-diastolic flow. Yes, if it is an extreme preterm baby, we give like the men feeds, that is around 10 ml per kg feeds for 24 hours or to 48 hours. We give the same volume feed and then we increase. We don't keep the baby's NPO on any baby who's having absent or reversed end-diastolic flow or a normal Dopplers. We start the feed soon after birth. If we get 1 ml 2 ml, it's very sufficient. So that's how we practice, and slowly we increase based on the gestational age and however they tolerate. And the feed intolerance, yes, in the study actually I felt like the sample size was very less. So they couldn't assess the number of necrotizing enterocolitis rates. I don't think they could do it much actually, because we see the babies when they feed, we see the feed intolerance. There's no specific definition for feed intolerance as such, because there's no consensus or guidelines. Even the ESPGHAN guidelines, that is enteral nutrition in preterm guidelines, which has come up in 2022, even they have said that there's no specific guidelines for feed intolerance. It's mainly based on the gastric residues or the vomiting of any altered milk or like that. So that is the main thing I want to suggest. And also and always it's always easier and it's always good and also benefit for the babies if we start early enteral feeds. Here they have started at 6 hours, but we are giving soon after birth. Actually, if we are getting men feeds, we are soon starting. There's no hours of life as such. If we get 1 ml 2 ml, we start soon after birth. If you don't get breast milk, we advise the donor human milk, but not the formula milk. And we have seen that babies who have started on early feeds have had early discharge from hospital, and also their time to reach full feeds. That is, we see in birth, preterm babies, they should reach full feeds by around 10 to 14 days. And if it's a more than 35-weeker baby, they should reach by 7 days. So we have seen that, and also the incidence of neck is also very less. Before and all, there are sayings like if you start early feeding, the chance for necrotizing enteritis colitis is very high. But I don't think that is said nowadays, because we are rarely seeing any incidence of necrotizing enterocolitis on babies who are started on early enteral feed. So I think, and also they have good anthropometric measurements when they go home. So I think early enteral feeding should be practiced. I think most of the centers, I think, right, PMC sir, they have started men feeds soon after birth based on if it's a breast milk or if it's a donor milk, and accordingly increase, and we just see if the baby is having any signs of neck. So that's how
Guidelines
we
are
go on.
easier now. Like Padmanabhan, Dr. Padmanabhan, remembering in Gulf and everywhere, even in India, before every feed we used to aspirate. Remember?
Now it's not
I think
suggested, sir, actually.
it is not at all. That is why I said the NNF, the things have been made easy. So continue feeding. If only there is abdominal distension more than 2 centimeters, or there's persistent vomiting of hemorrhagic fluid, hemorrhagic aspirate, then only you need worry.
Yes, and we don't aspirate any milk if it's a stable baby. Actually gastric aspirate is not suggested nowadays unless, like sir said, if there's any abdominal distension or if there is any altered vomiting. So yeah, that's it.
Thank you, Dr. Aditya, madam. I think it was a very interesting discussion, because it is very nice to know that whatever we have presented is taken in a positive way, and it's actually being practiced in most of the centers, and it will, I mean, the change is all definitely there. And today's discussion, we also came to know about most of the changes which has occurred in the area of neonatology also. The topic is open for discussion. If anybody has to contribute anything or anything to add, they are free to do.
Dr.
Desai.
Reshma?
From what I have heard, I would like to ask one question of the clinicians. Does this study add anything?
Yeah, definitely. One important thing I noticed is we can go ahead with slightly improved courage to start early feeding in this particular group. Because we are definitely waiting for 24, 48 hours. 6 hours, nobody has been trying. Maybe one or two cases like that. As a protocol, it's never come up. That is one thing.
Thank you.
Thank you,
Dr.
sir.
Reshma, you want to say something?
Yes. Yes.
Namita? Maybe no.
I think
No extra points,
there was Shana. I think Dr. Shana sir, Devakumar sir, all were there. I think they're not seen right now. Dr. Srijit, are there anybody in the audience who is from neonatology, from
Most of
SAT
them
or any other?
their comments.
Srijit sir, what is
Done a wonderful job and they presented well.
Yeah.
So congratulations to the presenters and as for the answer. Well.
Thank you.
Oh, I think I mean, the discussion, I think it was been very nice actually. It would have been gone a little further if more audience was there from the neonatology forum. But it is fine. I would like to thank PMC Nair sir for coming up with for his kindness to coming with this excellent discussion, excellent paper presentation. Because I think this is one of the best I mean, journal club presentations we ever had and are. We are thankful for that actually. And thank to Ramankutty sir, Dr. Arathi, Dr. Kamala, Dr. Gauri, Dr. Kavya, Dr. Padmanabhan sir. Sridhar sir, is there, you already said the vote of thanks, or?
Yes, we can wind up, sir. Just wind up.
Okay, thank you. Thanks for this, sir. Good day, sir.
Anyway, nice meeting Ramankutty and
Padmanabhan. Nice seeing PMC after a long time.
Yeah.
Thank you, sir.
Okay.
Thank you.
Okay, bye.
Thank you. Thank
So
you.
I think we can wind up.